Okay, good evening, everyone. I wanted to welcome everyone. We have 60 people here right now. We've had over 140 register to this conversation about autism spectrum disorder for parents of teens and young adults. It's part of a series. It's part of a series that we've done. Much inspired by Miriam Devora. I think I saw you out there, Miriam Devora. And Crossroads runs these programs as added value to the community, for the community, in a way to offer a therapeutic support to teens and young adults. For those of you who don't know, Crossroads offers a number of different services really focused on English-speaking teens and young adults in Jerusalem and really all over Israel. We have a clinic here in the center of Jerusalem, literally on Rehov Yafo, next to Coffee Bean, where we see over 200 therapy clients each year. We have a drop-in center. I'm not going to show it. It's on the other side of me. I'm not going to show it. Just have confidentiality, where teens come every night to hang out. We have a 24-hour crisis hotline. 24-hour crisis hotline for teens or young adults, to reach out if they're ever in crisis. We have a wonderful theater program, just put on production at the Khan Theater, and we do music and we do arts. Really our goal is to offer support. And whether it's a light issue or case or a much more intense, heavier case, Crossroads is there. The therapy that we offer is for free. Before it was popular to offer therapeutic support, at no cost. Crossroads has always been there trying to make support available to teens and their families in a meaningful, very, very accessible way. On that note, I'm going to, we have three wonderful speakers. We have Dr. David Pless, who's a psychiatrist and unit director of the neurobehavioral unit at the Abarbanel Mental Health Center in Bat Yam. We have Dr. Shoshana Fox, who recently gave a training at Crossroads, a child psychologist, play therapist, autism specialist, and the author of the parent-friendly and autism casebook for parents and practitioners, The Child Behind the Symptoms. And Elizabeth Cohen, a social worker, program director of the Yachad NJCD for 7 years, assistant director of Midrashet Darkenu, serves as a social worker supervisor one site. We have three different professionals really to bring different perspectives, different thoughts. Each one is going to speak for about 15 minutes. And afterwards, we'll be able to go into the questions that you've asked in the past, or that questions that you've asked in the past, or questions that you have tonight. Deliberately, everyone is on mute tonight, although Nechama is putting together questions that come up throughout the evening. Oh, I'm so sorry. Hakarat Tov to Nechama Levy. That's not your name. Nechama Levy, thank you, who put the whole evening together, really from the beginning, thinking with me, to making everything happen. So really, Hakarat Tov to Nechama, and in general to the Crossroads staff. So without further ado, I'm going to invite Dr. Bless to start. He's going to be speaking about behavioral disturbances for young adults with ASD. So I'm going to hand you the mic.
Okay, thank you very much. Good evening, Erev Tov to all of you. It's a real pleasure and privilege to be part of this evening. And really thank you to Crossroads for sponsoring it and for inviting me to participate. So it's a pleasure to be here this evening. The topic that I chose to speak about for a couple of minutes is that of behavioral disturbances in young adults with autism. As Robbie mentioned, I have the pleasure to run the neurobehavioral unit at Abarbanel Hospital, where we treat young adults from the age 12 to 21 with an autism spectrum diagnosis and behavioral or psychiatric disturbances severe enough to warrant inpatient hospitalization, and I treat this population as well in the outpatient setting. And I wanted to share with you all just a few basic concepts related to behavior, to disruptive behavior, and in terms of thinking about how to understand the behavior that we see in our, children and students or patients who exhibit these behaviors. Behavior disturbances are not part of the core diagnostic criteria for ASD, but as with many other neuropsychiatric conditions, whether it's Alzheimer's, dementia, Parkinson's disease, and many other neurological conditions, even though behavior disturbances or psychiatric disturbances are not part of the core definition of the diagnosis, they occupy a very, very large percentage of the energies and resources of families and of the systems, whether it's the educational system, the revacha, social services, or other professionals. Behavior disturbances among the ASD population are the main cause of the use of psychotropic medications. Whether you love them or hate them, believe in them or don't believe in them, they're used to a great degree, and it's generally speaking for the treatment of behavior problems. Discipline issues in school, the resources in schools, in homes, in group homes, such a large percentage of the resources are focused on the prevention and treatment of behavior problems. Behavior problems are the primary cause of placement outside of the natural home before the age of 21, and sometimes even after the age of 21. And as I mentioned before, an incredibly high percentage of the resources that are utilized with the ASD population are related to disturbed behavior of one type or another. So it's an important topic. It's a complex topic. 15 hours as opposed to 50 minutes might begin to scratch the surface. But I wanted to share a couple of, I'm not saying we should do 15 hours, don't worry. But, I wanted to share a couple of core ideas. So first of all, just the concept of behavior. Behavior is something that a person does. It's not a feeling, it's not a thought, it's not a belief, it's not a mood. It's something that a person is actually doing. And an important aspect for us, as whether it's clinicians or family members, is to appreciate that the definition of a behavior is not just a description of the motor activity, but it relates to the goals of the action. What do I mean by that? If I'm taking a fork and putting food on it and putting it into my mouth, you could describe it from a motor perspective. I'm moving my arm and putting food in the mouth. Or you can describe the goal of eating, which may relate to a certain drive, a certain hunger, a certain emotion. But it's not just describing the motor action, but it's thinking about the goal. What does the person have in mind? Or to refine that a little bit more, one can imagine 3 different scenarios of eating. One may be an athlete eating in preparation for a race. A second might be a married couple celebrating an anniversary in a fancy restaurant, and the third might be a Shabbat table or Chag table with the family and a spiritual type of overtone. In all 3 cases, describing the action of putting food in the mouth might be very similar, but the goals of that activity, whether it's the athlete preparing for a race or a couple on a romantic outing, or a Shabbat table, obviously has very different types of goals. And so when we think about disturbed behavior, disruptive behavior in the ASD population, it's critical for us to move beyond simply describing what happened, but to think more broadly about the goal of the student, of the child, of the patient when exhibiting a particular behavior. Now, disruptive behavior, or in Hebrew it's called hitnagut ma'adgeret, challenging behavior, which I happen to like that term, typically reflects the child, let's say, or the adolescent being out of sync with his or her environment in some sort of way. Oftentimes, the disruptiveness of the behavior to the environment reflects the fact that they have a very different goal that's motivating them as opposed to the setting. And what's critical to appreciate is that there are manifold causes of disruptive behavior. As I tell parents when they come to the hospital unit, the ani ma'amin, the underlying core principle of our unit is that behavior usually can be understood, it can be decoded, its causes and modifiers can be identified to one degree or another, and an appropriate treatment plan can be formulated based upon that understanding. So, in a very general sense, and again, this is a kind of a superficial skimming of the surface. We think about any sort of behavior. It's sort of the outgrowth, the kind of the pre-yotzer of internal influences, what the person, him or herself, is experiencing on the inside, combined with certain external influences. And I'll explain in a moment what I mean by that. Internal influences can be a very broad range. It could be a drive, a hunger, a thirst, fatigue, tiredness, sexual drive, aggression, and the like. It can be emotion. It could be an anxiety, a fear, a desire for closeness, among others. External influences are a little bit more complex. A person, any person or a person with autism may be influenced positively or negatively by the sensory profile of an environment. They could be influenced positively or negatively by the demands of the environment, whether it's academic demands, social demands, physical demands, or the like. And in a more subtle, or maybe a little bit more complex way, the behavior of any person, but we were talking about someone with autism, can be driven by the expected influence that their behavior will have on the environment. What do I mean by that? So to use a common example, a mother or father is with their young child in the makolet, in the grocery store around dinner time, and the child is hungry. They went there just to pick up a few supplies for dinner. And the child decides that he or she wants a chocolate bar, and they proceed to have a full-blown temper tantrum, with yelling and screaming and kicking and biting and throwing and hollering and everything else. So obviously they're being driven by an inner desire for chocolate, but you would agree that that inner hunger doesn't really explain the behavior of yelling and screaming. It's the expected effect upon the environment, hoping that a combination of fatigue, wearing down, attrition, embarrassment, impatience, and the like will lead the mother or father to give in and buy the chocolate. So here it's the expected effect of the behavior upon the environment. And so when a child or young adult is displaying a disruptive behavior, whether it's in the home environment, in the school environment, or any other environment, the people responsible for treating that behavior or dealing with it need to undergo a process of what sometimes called decoding the behavior, looking both at the inner state of the child that may or may not be driving it, as well as external factors. And not to overly medicalize the process, but physicians speak about a differential diagnosis, right? I have a headache. What's the differential diagnosis? There's a lot of things that could cause a headache. And the same way here, a person could think about, if you have a young adult with autism who's exhibiting a disruptive behavior, one could think about an abnormal psychiatric state, again, whether it's anxiety, depression, mania, hypomania, strong obsessions or compulsions, where one could perhaps come to the conclusion that the primary driver of that behavior is this abnormal psychiatric state. One could think about physical causes, constipation, pain, visual impairment, difficulties hearing, dental pain, and the like. Sensory overload, or the negative or deleterious effects of aspects of the sensory environment, side effects of medication, a not small percentage of hospital admissions that we take care of, on the unit where I have the privilege to work. Many times there are side effects of medications, whether it's traditional medicines or medical marijuana, depending on the scenario. Sometimes medicines have side effects that make things worse, features of personality, and of course the whole behavioral complex. So, in thinking about the disturbed behavior, the first step of the process is really trying to come to an understanding of the patient, the student's inner state, and if there's aspects of that which may be influencing the behavior. And at the same time, not before, not after, but at the same time, looking at the overall environment, the behavioral dynamic between the patient with ASD and what's going on around them. Just to give one simple example, I know I'll have a couple minutes left. We have many patients who end up hospitalized where the dynamic that led to aggressive behavior relates to inadvertent rewards that were granted to the behavior. So a child's going to school and they're doing well, and they're going and they ask for a day off, and of course they're not given the day off, and they're asked for to leave school early for good behavior, and of course they don't go home early, and then for one reason or another they hit the kid next to them and they're sent home for 3 days. So I'm not saying that it's always wrong to do that, but suddenly you have a environmental reward for bad behavior that, if it repeats itself enough times, can lead to the child learning in a Pavlovian, operant condition type of way that certain behaviors lead to results better than asking in a polite sort of way. And so these are things that we do, whether in the hospital unit or in the clinic. I just want to make 3 bullet points, and then I know my time is nearly up. Oftentimes, parents are conflicted when their child exhibits, let's say, academic aptitude that's much higher than their social or emotional aptitude. And the question is, what's the best way of identifying or labeling that child, high functioning or low functioning? And it's not an easy question. We think about school as being an academic setting, but a ihatama, a mismatch between the social demands of a scenario and the social abilities of the young adult, him or herself, will often lead to a worse emotional and behavioral outcome than if the emotional and social demands are matched and the academic demands are mismatched. That's something that we see often, especially in the clinic. And a second point, and this is really both for schools and for homes, the value of hadrachat horim, or of nituach hitnagut, of having a behavioral specialist work with the parents, the child, and the school environment, is something which, in my observation, is maybe underutilized. And a ideal behavior plan will link together the all the environments where the young adults finds him or herself: the home environment, the school environment, social environments, to try and have all of the adults who work with the child or the student utilize a similar approach, whether it's in the way that the child is spoken to, whether it's the way in which the environment responds to appropriate or inappropriate behavior. And that's something which is extraordinarily valuable, often leads to us being able to minimize the use of medication or avoid use of medication completely. I think my time is basically up. So thank you very much for your attention, and look forward to hearing the next 2 speakers.
Thank you very, very much, Dr. Blast, for kicking the evening off. Now I'd like to welcome Dr. Shoshana Fox, speaking about looking beyond the autism diagnosis, why and how. So, bevakasha, Dr. Fox.
Okay, thanks very much, Robbie. I'm just going to call it up, and I'll just need a audio cue from you that I've actually shared screen properly, okay? Because I prepared a brief PowerPoint, and let me just see if I can do the share screen stuff. Oops, it's disabled participant screen sharing, so I need you to enable that. What? I'm sorry, I can't hear you.
I'm not sure how to do that. I would just
This could
move
be-
I would just move ahead with the frontal presentation.
Oh, without the, is there's no way to get the visuals? Quick like a bunny? No?
I'm not sure how to do it at this moment. I would just move ahead with it.
Okay, all right, okay. Can you still, you can still see me when I call up my presentation? I'm reading off it.
Yeah.
Okay, great, okay. So I'm going to be talking for the next, looking at my clock here, for the next 15 minutes about looking beyond the autism diagnosis, why and how, and presenting work. I had the great blessing in my life to work for 25 years at a place called the Feuerstein Institute, which is still going strong, really alive and well. And my role at the time was to assess and treat children with special needs of all kinds, especially those who'd been diagnosed as autistic or were suspected as being autistic. And in addition, I provided parental guidance and counseling to the parents who obviously were very, very much wanting that. My work, even now, is really rooted in those many years at the Feuerstein Institute. So if you hear me sort of moving from past to present, that's why. So I'm telling you about my roots, but it's still functional now. So we worked and we work, the Institute works with a very unconventional perspective, one of optimism, positivity, hope, and tachlis. And by that, I mean hard work. If we saw the potential in a child, in an adult, we spared no effort to try to realize.
Shoshana, do you want to try? I made you a co-host. Someone suggested.
Oh, that's brilliant. That's great.
Well, whoever
sure, let's give it a try. Oh,
suggested, Daniela Plutchuk. Thank you.
All right.
Let me see if you could share.
I'm going to go in here and share screen. Oh, I'm so glad because the colors kind of help. Can you see that screen now?
Yeah.
Oh, that's great. Okay. I'm just gonna, there. So we're talking about, optimism, positivity, hope, and tachlis. And really is kind of a positive psychology. It's very, very positive kind of gisha. And if you were never exposed to the professor, he's famously quoted as saying, I will never give the chromosome the last word. Well, he might just as well have said, I will never give the diagnosis the last word, because it's not that we ignored children's problems. We very much attended to them, but we put those diagnoses aside because we want to know who is that child behind the diagnosis. And for parents who are out there and for professionals out there, here's a very interesting resource for you. You love me, don't accept me as I am. Isn't that a switch? Usually parents are counseled, you must really accept your child as per a certain diagnosis. And no one's talking about rejecting the child, so don't worry. It's very, very positive, very, very warm and full of spirit. We also were guided in our work, and it guides me to this day in my own work, to see autism as a state and not a trait. And I know that there's a lot of genetic research going on out there, and the professor would say, even if they discover a particular gene tomorrow, we're not going to give it the last word. We're going to keep working to realize the child's potential. So everyone, I presume, knows that a trait refers to your, for example, something that's genetic, your eye color, your hair color, your body build, your height, and so on. But we saw autism as a state, and therefore it was modifiable. And modifiability was the absolute watchword of our work. Absolutely. In other words, human being, then you're modifiable. Here's another some food for thought. An autism diagnosis does not have to be destiny, the definition, or a determinant of the individual. Just going to throw that out there. And one of the phrases that I think I thought it up, I'm not sure where I got it, but it really guided my work and continues to guide my work in everything I do, is really the child behind the symptoms. Yes, we have to see the symptoms, but we have to see much more according to this kind of philosophy. We have to see much more, or we've really sold ourselves and the child short. So speaking of symptoms, I just want to take people very, well, really in encapsulated time. This is, Dr. Blass said, you know, like 15 hours, yeah, same here, but 15 minutes, we're going to do it. This is going to be lightning fast. I just want to show parents in particular, and at the Institute, I would absolutely show this to parents of how the diagnostic criteria for autism have changed, and because I want them to understand what has happened in the field and why so many children are being diagnosed. And I'll be honest, in my perspective, often, but not always, misdiagnosed with autism. And if we look back 80 years to what Leo Kanner said, look at the stuff in orange. Overwhelming aloneness and cutoffness, separation from the world, overwhelming, obsessive insistence upon sameness. That's very intense language. Look where we are now in a nutshell. I'm not going to go into all of this. This is just lightning fast. If you think, consider, this is from the Diagnostic and Statistical Manual of Mental Disorders, the 5th revised edition. And there's so much to say here. There are many problems in this configuration, and I'm by far not the only voice that is saying that these days. But okay, problems in social communication and social interaction. And you can get a tick for each one of these, 1, 2, or 3, whether social emotional energy, you know, kind of a back and forth, or nonverbal kind of communication. Does it sort of match what you're trying to communicate? And number 3, deficits in developing, maintaining, and understanding relationships. I think, well, does anyone know anyone that doesn't have a problem in developing, maintaining, and understanding relationships? So there's certain problems at that level. There are also problems in this big yellow word that's taken right from the actual text in arranging. So when you get a range of symptoms from light to extreme, I think we've got a problem. And I think that explains why, from my perspective, a lot of children, it's being overused, and a lot of people, children with various social and communication problems, are being misdiagnosed as autistic because the criteria are so incredibly elastic. They just expand. Evidently, that was done on purpose to enable parents to get the services they need, and that I completely respect. Unfortunately, in doing so, this diagnosis is rather problematic in my estimation, which doesn't mean the children don't have problems. It just requires a lot more of it from us to find out what those problems are behind the diagnosis. So for example, just to take another example, and then I do want to give about half a dozen pointers and so on that have really guided my work. Some I learned at the Institute, some from my own practice. So let's say you went to the doctor with a cough, and at the end of the appointment, he said, don't worry about it. You've got coughing spectrum disorder, CSD. And I don't think, parents, I don't think you'd be happy with that. I think you'd want to know what's causing my cough. And similarly with developmental problems that appear to be autism. Just a second. And just one other kind of technical thing that I want to encourage people to consider before I get into the recommendations. The same symptom can have many possible causes or roots. So someone could have a communication problem. Here's one right out of the DSM, failure to initiate or respond to social interactions. That was right in there. I put it in orange. I'm not sure if you noticed it. Well, let's just sort of quickly brainstorm some reasons why a kid might, or teen, might get a tic because they're having some social problems. They might be underconfident. They might have, God forbid, experienced some kind of physical or sexual abuse. They might have witnessed domestic violence. They might have an objective problem in word processing, word retrieval, or language production. They might have experienced trauma, as we all are right now. They might have a hearing impairment that's not been really calibrated right to explain their problem. They might have a general developmental delay that's really not categorizable, and that's okay, as long as we know what to do with it. They might be gifted and not all that interested, but not necessarily autistic. Or they might have genuine autism, which for me goes back to the roots of those really too tight criteria of Kenner. I think that's really important. And I would share this with parents, particularly parents who are in distress at their child being diagnosed as autistic. I never dreamed my child was autistic. I knew he had problems. I said, look, I think I have good news for you. Let's have a look at the criteria and see some of the problems with them. So in terms of supporting parents of children with special needs in social communication, which sometimes included autism and sometimes it included autistic-like behaviors. Let me share with you some of the nuggets, some of the things that they might look on the surface. Well, they're so simple. What's, how is this going to make any difference? I'm looking for miracles. Well, miracles sometimes take longer, but it can come. Oh, here's a term that the professor coined, islets of normalcy. In the whole sea of symptoms, we saw the symptoms. No one was denying the symptoms. No one was trying to say, oh yeah, well, this kid is fine. No, we see where they're stuck. We see they're having, but where are the normative behaviors? Where are those islets of normalcy? Where's like little attempts at verbal or nonverbal communication, making eye contact, little expression of interest in connection, relationship, little sense of energy flow, flashes of warmth and humor, interest in play or interest in sports, I guess, for teenagers. So often, you can think of the islet of normalcy as an anti-symptom. So often parents are so overwhelmed with the symptomatic behavior, and I completely sympathize and empathize, that these islets of normalcy are, yeah, okay, we had a few good minutes. And what I would encourage, and my colleagues as well, is I encourage parents, and this is part of the recommendations we're at now, become a super sleuth at noticing your child's, teen's islets of normalcy. I realize this requires guidance. It requires more than a 4.5-minute crash course in this. Highlight them in your mind, bring them into the foreground, and pay special attention to them, because that's the child behind the symptoms, showing him or herself. Respond in some warmer relational way, verbally or non-verbally, and able to help those islets grow. So that's a lecture of an hour in itself. Talk to your child. Here's another resource parents, from the professor's team, a think aloud, talk aloud approach to language building. And parents say, well, yeah, I would love to talk to my child, but like, duh, he doesn't talk. This method actually warms up the language, the expressive language channel, by increasing input to receptive language, to language that's heard. In a nutshell, describe just what's going on. Just describe it like you do your other kids. Oh gosh, I forgot where I put the whole wheat flour. Just talk to your kid. Use statements as much as possible. I mean, obviously you have to question and rather than questioning or quizzing the child, because when we're questioned, we sort of get defensive. Be on the lookout for those little islets of normalcy, for little opportunities of verbal or nonverbal communication your child or teen may be giving you, and just let that energy, respond to them with a look, a smile, a word of encouragement. I got you. I see you. I heard you. I'm angry. Why'd you get mushroom pizza? Oh, you really didn't like that. Thank you for telling me. Halavai, they were speaking like that. I realize that. But begin communication where your child is. I admit I've not read the book, just the article about this book. But Ron Suskind, and his whole family followed his autistic son's interest in Disney characters and created a language breakthrough for their child. This was really important, and it remains important to me. Seek out practitioners, I would tell parents, who see your child's potential, who see the child behind the symptoms, which we're going to assume from this Google image picture that this woman sees the beauty in this child. And if you encounter, and I hope you don't, but if you encounter a professional that says, your child will never, because he's autistic, he will never, I would say with all respect, keep looking. There are some great practitioners out there. Keep looking until you feel you've found the resources where they get it and get your child. We were very much, and I continue to be very much in favor, pro-educational and social integration and inclusion. And I'm really looking forward to hearing what Elizabeth Cohen has to say about that. We were real fighters, and I'm sure that the staff that is still at the Institute are real fighters. And dads out there, you are important. I find that often the dads really suffer when their child is diagnosed, and perhaps are in some ways respond to it differently. And I think it's important that we as professionals give support to the dads, and I encourage the moms to do the same. Less nagging, but more support, and giving them some practical ideas that they could do to help them feel connected to the child that may have a social communication problem. And one more, I believe, be courageous. This is addressed to parents. Be courageous in trusting your instincts and your understanding of your child's strengths in particular. Obviously, there are going to be times you're genuinely confused and do not know what is the right thing, which is the right setting, which is the right professional. That's completely understandable and completely understandable under the circumstances. But there will also be times when well-meaning professionals will be telling you something and your gut is screaming, I don't want that for my child. I want something else. And I just want to encourage you to be courageous in trusting in those moments, to be courageous in trusting yourself. And thank you. Thank you, Crossroads. Thank you very much, Robbie.
Okay, wonderful. I want to okay, great. Thank you. Thank you, Dr. Fox. I wanted to encourage everyone again. Nechama, who's a co-host, Nechama, maybe send another note in the chat. She's taking questions. We received a lot of questions in advance, and we'll get to as many of them as we can. And we'll more focus on questions I think could be extrapolated and more generalized, and not very, very, very specific to a particular unique situation. Anyway, I wanted to welcome Elizabeth Cohen, a social worker, to talk about mainstreaming and self-acceptance. Thank you for joining, and it's all yours.
Thank you so much, Robbie. Thank you again also. First of all, everybody here this evening, I can't see all of you, but the few squares that I can see, thank you for joining, and thank you for inviting me. So first of all, I'm coming from a very different perspective. I am coming a little bit less from a clinical, I am a social worker, but I'm coming a little bit less from a clinical background and a bit more from an administrative background and a programmatic background. Before I made Aliyah in 2001, I was a program director at an organization called Yachad, specifically in New York City, where I oversaw various types of programs, Shabbaton specifically. I also ran a summer program called Yad B'Yad, which brings high school students, a mainstream population, along with this disabled population and the whole spectrum of disabled population for summer trips, sort of a leadership program and a mainstream program. So mainstreaming was a big part of my essence for almost a decade in New York. And had a lot of, mainly with the high school population, yeshiva high schools. And then when I made Aliyah, I became the program director of a school called Midrashet Darkeinu. Midrashet Darkeinu is a seminary, a post-high school program. There's a women's program called Midrashet Darkeinu. There's a men's program called Yeshivat Darkeinu. The women's program is housed in Midrashet Lindenbaum, within Midrashet Lindenbaum, which is located in Tel Piot. The men's program is on the campus of Yeshivat Har Etzion in Gush Alon Shvut. And there we do a program, we've sort of renamed it side streaming as opposed to mainstreaming. And I'll explain sort of what mainstreaming, at least from my experience, has been. What is mainstreaming? What is the goals of mainstreaming? What are the pros and cons of mainstreaming? And sort of where we have developed sort of this concept of side streaming at this point. Full disclosure, my programs that I've worked in run the spectrum of disabilities, including young women and young men when I was working in New York, that would be labeled, for lack of a better word, ASD. But many of our students that I work with also have classic challenges such as Down syndrome or cerebral palsy, etc. But to get back to the idea of mainstreaming as a concept, the idea behind mainstreaming is just that, to help the disabled population integrate socially into the mainstream population. But I will go so far as to say that you need both groups, and both groups have to be educated simultaneously for the goals. Meaning, I think as much as we're trying to help, at least, and then we'll talk about someone on the spectrum, a child on the spectrum, we need the mainstream population to become sensitized to the differences and the uniqueness of the disabled population, if you will. You cannot have both. You can't have one without the other. Years ago, when I worked at Yachad, when I would run Shabbaton, so before I would do a Shabbaton, I would sit with the high school students and I would sort of do a little bit of a sensitivity training and an explanation of what are we about to expect when we spend the next 25 hours together. And one of the ways I sort of explain to them what's their role in the Shabbaton is, I would say, we're going to be working long or spending Shabbat together. And one of the things we're going to be working on is sort of helping our new friends integrate. What do I mean? And they're going to be picking up social skills via having a fun social activity. I used to say and I would ask them, how many people here know how to tie their shoes? They'd all raise their hand. And I said, who taught you how to tie your shoes? And usually they would say a parent, a sibling, maybe it was a teacher. And then I would say, and who taught you how to have friends? And then there'd be a blank face. Nobody sort of knew how to answer that question. And the whole gist was to help everybody understand that nobody ever sat them down the same way they sat them down to tie their shoe. But through experience, through play, through social interactions, and sometimes from parents saying, hey, we don't hit Timmy, you need a timeout. But for the most part, all these things are learned amongst their sort of socialization. And with this population, oftentimes it's not always, for various reasons, it's not learned. Sometimes there's the deficit, but there's a sort of vicious cycle that because of some certain behaviors or certain issues come up, they don't have as many social opportunities. And because they don't have as many social opportunities, it gives them less experience. And when you add to the ASC, where you have sometimes challenges or oftentimes challenges with eye contact, with reading social cues, with being able to understand body language and et cetera, you have those challenges. But there are ways to teach social skills, just like there are ways to teach somebody how to tie a shoe. You can break down many social skills into teachable, acquirable skills. These skills, these social aspects can be anything and everything from how do you enter or exit a conversation? How do you make eye contact? How do you modulate your voice? Hygiene. Now, these are things that we didn't talk about on the Shabbat Tones. These are things that we talk about in my other program, which I'll get to in a second. But the concept that mainstreaming needs two groups. It needs the special needs population, or the young men and women on the spectrum, and you need a population that is willing to also understand them as well. We want our children to have better social senses, but we also want the people around us to become sensitized to us, and to hopefully engage with us, and also to accept us. I think there was maybe this wasn't what it was meant for, but there was a slide on Dr. Fox's presentation that said, start where your child is, and there's this balance of, at least in my experience, is we're always running to teach them exactly how to integrate, or how to give them all the right tools. But at the same time, there's a lot of nuances that we can't always teach. And again, as Dr. Fox had said earlier, sometimes when I run social skills classes, and maybe there's a social work intern who's watching us, or somebody from the outside who's experiencing it, they'll say, well, I actually have a neighbor who could use social skills, meaning social skills runs the gamut for most of us. And we can see it in various people not labeled with anything in particular. So that's the concept, at least from my perspective, of, what is mainstreaming. I'm talking about it in a social situation. And from my Yachad days in New York to coming to Israel, working specifically with post-high school students, we see a whole other side to post-mainstreaming. Meaning, when I worked in New York, I saw my participants for 25 hours, or even for an entire summer, a whole month, where we would tour. It was very curated, our trips, meaning there were high school students who signed up specifically for this kind of a trip, who wanted to be around young men and women with special needs, who were excited to be with them. And so the whole setting was not particularly organic, if you will, but it was a beautiful experience, I think, for everybody involved. One of the fascinating things, though, about this is like I said, it's a little bit inorganic, and that can be, as much as there's so many positive aspects about that. The challenge is when it's not in an organic setting. What do I mean by that? When the high school students came on the summer trip, when they come on the summer trip, and they're all prepared to be spending a glorious summer together with their special needs counterparts, and they're raring to go, and they have, come sit with me on the seat next to me on the bus, and let's do this activity together, and let me help you with that. And that pretty much happens throughout the entire summer. Then there's always one or two high school students who don't quite fit in. Now, I'm not suggesting they were necessarily on the spectrum at all. They just weren't the coolest of the high school students, but they also weren't Yachad members. And somehow those are the ones who sort of got left out. And it was just a really fascinating thing to watch. I mean, again, we're talking about 15 and 16-year-old young men and women, where, high school students, we can't expect too much from them. But there was almost every year a real opportunity for us as the staff to really address within the high school students how easy it was for them to find the patience and have the patience, and the excitement and the acceptance of their special needs counterparts. That was the easy part. The hard part was, how do they include, or how do they have patience, or how do they accept the non-labeled quirkier high school student who didn't quite fit in? And it was just a really fascinating thing to watch almost each summer. And I would address it with the high school students, not necessarily in front of the person who was maybe feeling left out, but maybe I would pull out 4 or 5 or 6 sort of leaders of the high school groups that I felt I could talk to directly. And there was always sort of this turning point of like, you have the power to use, your coolness for good and for exclusivity. And it's the same group who signed up specifically to be inclusive and were inclusive. It was easy to be inclusive with the young person with Down syndrome, or the young girl in a wheelchair with cerebral palsy. It was much harder for them to necessarily have the same patience for the quirkier, socially off high school student who also signed up for the program. Now, it'd be interesting to look back and see if there were more social deficits, but it didn't really matter. It was really about the mainstream population being able to accept everyone. So those are some of the challenges sometimes that I've watched in a small piece. And then when I made Aliyah and I started working at Midrashat Darkeinu, I really started to sort of see it in a much bolder way. What do I mean by that? So here, these young women in my program come to Israel for the year, and they are housed within our program. Like I said, is within a larger school called Midrashat Lindenbaum. We have dorms upstairs. The other Lindenbaum students have dorms upstairs. There's actually a Spanish-speaking program. There's a lot of different programs there. This is an Israeli program. So we're a little program within a much larger program, and that's wonderful. What would happen is, again, if a young student of mine had Down syndrome, it was very obvious that they belonged in my program. And that's how we started 20 years ago. But as the years have progressed, we have gotten more and more students who don't quite fit into what would be considered the special needs population by definition of Down syndrome, but are definitely more on the spectrum. And the challenges of socializing and being comfortable in our program. And we always say, we can't accept somebody who's not going to be able to be in our program, because if they're not comfortable, then they obviously don't belong here. But most of my students who are considered on the spectrum would love to have been in a program like Lindenbaum or another mainstream program, a typical program. But maybe academically they could handle it, but socially, especially being away for an entire year, it's just, it's very, very difficult. They weren't accepted at other programs. Sometimes we'll get a student who got accepted initially at another program, and after a month or so, socially could not keep up, and somehow made it to our program. The fascinating part is that they have their challenges, and they struggle. This is where they struggle with sort of, who am I? And all of a sudden they're faced with this real defining moment of, well, am I a Darkeinu student or am I a Lindenbaum student? I don't feel I'm this person, but I'm not quite this person, because the Lindenbaum students have been sensitized to be wonderfully accepting for a Darkeinu student. But if you're that quirky student in Lindenbaum, I'm not going to accept you so easily. And such is the nature of the world. And so when they come to join us within Darkeinu, even if they're struggling internally, and sometimes they are, ultimately they're in a much safer place. And ultimately, as much as sometimes we get pushback from I'm thinking of a particular student I have this year. I have a wonderful student from the UK, and very bright, very articulate, very capable, much more capable than most of my students. Certainly, not just academically, even just being able to navigate, being in Israel, taking a bus on her own, time management she's not great at, but she can't quite keep up with the Lindenbaum programs. And now academically, it's a very big range. Academically, Lindenbaum is much stronger, much higher. And she's okay with that, meaning she's okay that she can't keep up academically, but she struggles with not being able to keep up socially. And so when we have a choice of either going with a Lindenbaum program or staying with Darkenu, her first choice is to go with the Lindenbaum program. And where we can give her the support, we do. But oftentimes, when she goes with them, she doesn't quite get the social support that she would like. And she oftentimes comes back deflated and frustrated and down. And the same thing when I don't see the same thing when she's with us in the Darkenu program, but I can also appreciate that there's this nuance, that it's really it's a struggle. And I think that what happens in high school, that there's sort of these very obvious paths but people are sort of set up, whether it's a Yachad program or whether it's in your communities, your schools, your out of school, your social activities, that there might be this sort of mainstream group that's around for them. But once they hit high school, once they hit out post high school, whether they're going off to college, or they're going off to gap year, or they're going, and then romantic relationships, et cetera, that the division gets a little stronger. And I guess I don't really have an answer. I just sort of sharing with you sort of what I see when they come to this gap year program. And we work really hard at self-acceptance. We work really hard at being honest with what's hard for them and what they want and why they're in our program, and why there's things about our program that are good for them, and there are things about their program that are not matim, that are not appropriate, and where we can individualize, and where we could say, you know what, you're going to go with them, to this. They went to Kfar Aza. They took the group to, now we weren't going with our group, but one of our student wanted to go with them. And so she went with the madricha because we'd felt that it would be, obviously better for her and for everybody else. But where we can build a very unique and individualized program for them is what we see. There's a lot of nuance. And as they get older, I think the nuance is just more and more. And we work on that self-acceptance. We work on real connections. I have such a range of students in my program, not Down syndrome, across the board, that sort of, you're not quite sure who they are and why they're in my program, but the very fact that they're in my program means they're in the right program. And we work on real friendships that aren't just sort of one-sided, of someone being extra nice or going out of their way. And we have a therapist on site. We do a lot of therapy. We do a lot of talk therapy. These are sort of the approach that I have about. It's about honesty. And I loved again what Dr. Fox said about, you're not the diagnosis. You're not the diagnosis at all. But at the same time, I'll just say, though, we have to work within that framework, that there are challenges that are going to come up that we have to be realistic about, or we have to figure out how are we going to address them. A parent, I'm sorry. Okay.
Just one more minute. I'm happy your last sentence to finish up.
Okay, so the last sentence, I was going to go into another story, but I won't use that story. My bottom line is, I think it's as challenging as it is, I think that as long as we're looking at our, as our students or our children as individuals, but at the same time being very honest with what is their future and how can we help them be honest with themselves and happy with themselves and happy with their limitations, but also and accepting of their limitations, but also working on integrating and how we can be in a social setting. I think that is the most that we can give our children.
Okay, thank you. Okay, let's unmute everyone that needs to be unmuted. Before anything else, I do just want to say one more sentence about Crossroads. I said it earlier, I just shared it with the group. One of the main things that we do for the community as a whole is offer fully subsidized therapy by professional social workers, supervised and professional trained social workers here at Crossroads. And we really, anyone that needs that, whether it's hasn't worked in the past or someone wants to try it out, they could always reach out to us. The phone number is in the chat. And the other thing that I wanted to mention is something that has saved lives, and it's also been there for people on the jam, which is our crisis hotline. 24/7 Crossroads social workers would be there to answer a call from a teen or a young adult. Feel free to share with yours. Okay, I've muted everyone that needs to be unmuted. We've gotten a lot of questions. The question just came in a few minutes ago that I wanted to put out there. Every person has strengths and weaknesses. Why is a high-functioning ASD considered a disability? It has strengths and weaknesses too. Someone want to jump in there?
I don't want to jump. I'll jump.
Okay.
Okay. I hope this, why is, well, you're talking to a psychologist that doesn't consider it a disability. So I don't know if that's the end, if that's the answer that you were looking for. I have to say also that there are a lot of terms out there. I'm just saying this because I think it's important to know that there's different ways of looking at this whole challenge of the use of the word autism these days in particular. And I personally in my career have not used the high functioning autism term, because I think a lot of times it's completely normal and highly intelligent and children with enormous, terrific potential who have some social, emotional / communication issues that can be worked on functionally, and then off you go without the labels. So I'm not sure, where the parent was coming from, but I certainly do not see that as a disability in the same way. Yeah, your person does not equal a diagnosis. You want to see the person behind the diagnosis, and so I just speaking for one.
Okay, thank you. Dr. Blass or Elizabeth, do you want to add anything?
Maybe just a couple of words. Like with all conditions, we're dealing with people, and the need to avoid stigmatizing and labeling. On the other hand, the concept of disability been historically a very important one in pushing society to develop the resources, accommodations, understandings, and flexibilities that allow people with a problem or a challenge to engage in general life in as independent and successful a way as possible. So, for example, just the existence of wheelchair ramps and accessibility in a very general sense, by recognizing that there were people with limitations or disabilities that needed certain accommodations, even by law, allowed much more engagement. And without getting into which people with high functioning autism really should or should not be diagnosed with autism, there certainly is a subgroup of people who, despite having very high intelligence, without proactive treatments, accommodations, therapies, educational programs, and the like, would not be able to manage the emotional and social demands of typical life, whether it's holding down a job, having a family, or living independently, and recognizing a problem as, let's say, disability pushes the system and society to demand solutions for these problems. So it's not a question, will the person become a lawyer or a mathematician or an artist versus versus something else. Severe weaknesses in emotional regulation and social functioning will often preclude any type of general functioning without society proactively providing solutions and therapies for these people.
Got it. Liz, did you want to add?
I think that was very clear.
Okay, super. I'm going to move on to another question we got early on. And this is something that you know I hear a lot about just amongst hearing kids talk as well. And it's something that's on my mind as well. So I'm a little bit biased to the question. The question goes, my daughter and her friends talk a lot about the ways in which they are neurodivergent, or their diagnoses, I'm adding, to the degree that I'm concerned that she's focusing too much on things that are challenging for her. How can I focus on her strengths? How can I best support her regarding her challenges, which include sensory, social overload, difficulty sustaining energy and attention, while also encouraging her to have high expectations of herself? Liz, do you want to start off with that?
Well, I'll start off by saying I'm assuming this is a teen, and I
Yeah.
think to the extent that we're talking about adolescents and their challenges of self-definition of finding their groups, meaning to a certain extent that this is, I think, not just a challenge for somebody on the autistic spectrum, but I think that you're dealing with adolescents who are in struggle in this time, and to be, I think if you're not looking at it within that framework, I think you have to look at it within that framework, and that many teens are trying to find cliques, find groups, find their understand who they are, and latch onto people and latch onto their groups in order to have that perseverance and self-esteem. So I think that's the framework you're working within, and you can't discard that, in my opinion. You can't discard the adolescence angst, the adolescence aspect of it. I think in terms of, can you repeat the second part of that question?
Well, the first one was basically their self-diagnoses, and well, not self. I added that. I take that back. The first part was about they would talk a lot about it, maybe to the extent of enabling themselves. How can I focus on her strengths? How can I support her regarding their challenges? But while also encouraging her to have high expectations of herself.
Right. So I'm saying, when you're talking about teenagers, I think that could be a struggle for a lot of parents across the board. And I think just that, I think that you do talk about his strengths, you do mention them, you do advocate for them, you try each angle. Maybe I'm wrong. I do not think you're going to be able to be productive by trying to take them away from this group or take them away from speaking about what they speak about. And I think that they are finding themselves. And I also think that how they define themselves at age 16 and 17 does not necessarily mean that that's what they're going to be at age 40. And I think maybe it's scary that our fears, and I understand it, of, is my child going to have this label or this diagnosis, and then it's all over. And that's, people evolve, our children evolve. These are not going to be their only friends. This is not going to be their only social experiences. But right now, they're in such a small bubble that I think realistically you have to understand that piece. But as much as you can, find avenues and venues to open them up and broaden them up and speak to and find those positive pieces, and include them in that as much as you can.
Got it. Dr. Fox, Dr. Bless, do you want to add?
Sure. Yeah, I jump in on that one. I'd like to add, I would say to that parent, trust yourself. It was very interesting. You sent the questions out, and I was reading that one ahead, and I thought, how interesting. They're talking about that they're neurodivergent and so on. And I think that I'm getting the feel this mother is, very, very very sensitive, very intuitive, and right on. In other words, what I would like to say to that mother, whether she's in the audience or not, is don't let the word neurodivergent undermine your confidence in yourself as a parent. In other words, I'll just say as an aside, and it may, you know, it maybe sound strange, but there are a lot there are a lot of words in use right now around the term autism and ASD and all that I don't use. I don't use the word spectrum. I do not use the word neurodivergent because I'm not a neurologist, and people for referral information do not send me MRI results. So I don't know if they're have different, you know, I haven't seen their brain scans and wouldn't know how to interpret them. So for me, I'm interested in the person behind the symptoms. And what I'm trying to say to this mother is trust yourself. You're a parent concerned about your child identifying with something that you think is not to their advantage. Trust your gut. You're right. You're right. Help her find her strengths, reflect her strengths, just as Elizabeth said, as you would with any child. There's no mystery in her, and in that, and trust yourself.
Thank you. Thank you. I'm going to go to the next question, unless Dr. Bless wanted to add. No. Next question I think is very, I think it's a very meaningful question because, you know, like you spoke about, Dr. Bless, initially, there are a lot of behavioral issues that come up, and a parent wrote a question here: how can you not burn out? It's like 4 or 5 words, but I think that's part of the reason why we're doing this whole evening, to be able to offer parent support. And sorry for the very large question, but any thoughts about giving parents, tools for themselves in terms of not burning out from all the struggles all the way through, whether it's the behavior or whether it's the diagnosis or what, etc. Dr. Bless, do you want to start?
Sure. Yeah, I think I would very, very much connect to something that both Elizabeth and Shoshana said a minute ago. The question is really a subset of the general question of burning out or not burning out, life in general, parenting in general, and parenting a child who's particularly challenging, for one reason or another, including ASD. I think parenting a child may be particularly challenging in terms of burnout, but the general approach to avoiding burnout is a combination of adding meaningful support to reduce the burden on any one particular parent. That support can involve professionals, family, community resources to help sort of, share the burden in a very general sense. It can include developing parenting skills to the maximum so that the challenge of raising the child and managing their behavior or other issues is dealt with as successfully as possible. And the other half of managing the burnout is, what today we would call self-care, meaning finding scheduled, structured times throughout the week, not just for rest, but for rejuvenation. It could be, I usually speak to my patients, to the caregivers about, social, intellectual, spiritual, and physical activities that are peppered throughout the week on a predictable basis, where we rejuvenate ourselves, gives ourselves chizuk, reignite our spark, remind us of parts of ourselves that aren't just parenting a challenging child, and utilizing that. So a combination of meaningful help and support, as well as a meaningful and appropriate self-care.
Okay, thank you. Liz, Shoshana, do you want to add anything about
maybe
parents?
Yeah, just it also occurred to me that communication, in addition to the self-care, finding someone that you can vent with, I think, is really important. It might be your spouse, hopefully, and if not, if your spouse, that's not that person's style in terms of listening to, you know, the spouse's problems and so on. A good friend, a professional, a counselor, when you feel you're drowning, to there's no shame in that, because as Dr. Blas said it, you know, the stress goes with the job, right? The parenting, it's just, there's no way around it, 24/7, and not to be embarrassed or ashamed to call up a friend or call up whoever you need to vent and feel you're not in it alone.
Okay, thank you. Okay, let me move on. A number of people asked about, you know, it's a little bit technical. I'd like to, I'll ask it. Just wondering what the maybe similarities or differences with ASD and ADHD. You know, I don't know if that's something that's come up for you, or if it's, you know, you'd like to relate to it briefly.
I guess I'll jump in. First of all, this may not be the intention of the question, but historically, the diagnostic concept of ADHD and ASD share a lot in common, meaning as clinical syndromes, they've both been recognized for a long, long time as initially encapsulating only the most sort of extreme presentations of a problem. You know, the kids with ADHD that we would all agree have it, can't sit still for more than a fraction of a second and the like. And the people with ASD, who there's no question, you know, they have something that's very different than just quirkiness or, you know, some social communication challenges. And over the years, both the concept of ADHD and ASD have expanded, you know, again, by design, have expanded very, very significantly. So in terms of like nomenclature and diagnostic conception, they're both very, very similar. And certainly it is the case that a large percentage of children with ASD also meet criteria for ADD or ADHD. But having said that, the core symptoms that define ADD or ADHD and ASD are very different. Some children with ADD or ADHD may have a hard time reading social cues, but one doesn't need that in order to have the diagnosis of ADD or ADHD. And certainly there's plenty of kids with ASD who don't have ADD. It certainly is the case that the more psychiatric or neurological comorbidities that are added to a patient with ASD, the more challenging of a time they have integrating socially and academically or within their family. And so these things do need to be looked out for. But okay, I'll leave it at that.
Okay, I'm going to jump to another question because there's a few others I wanted to get to. Some practical suggestions how to engage the entire family with a autistic young with an autistic young adult sibling. Liz, do you want to?
I'm sort of curious, like what that means, how to engage them. Meaning, are they struggling with having activities to do together or to connect with? I would say that if that's the case, you know, to try and find something that they have in common. Oftentimes, the child on the spectrum may have a very hard time relating or connecting. And again, maybe it's coming from that sensitivity training that I run usually, is where can we meet the child at that place? And maybe it's you know, it's in a setting that is going to be good for that young person in the family. I don't know how young that person is. How can we make an activity or make a connection with them? So I don't know if it's that, or it's that there's issues like with siblings and fighting, and they're not being able to get along and to be able to figure out the dynamics in the house. I will say that the family is you know, the family dynamic can be a big challenge. I remember a parent came to visit their daughter I don't think she was on the spectrum per se, but one year in Darkino. And one of the things the parents said was, wow, this is like the first time we've ever had a regular year without our child sort of taking up specifically Sundays. Sundays were really hard for them because Sundays became all about Samantha, their daughter Samantha, and because she had to get up really early and she was running around, and it all became about Samantha. So, and that was the focus. And it became the focus when she went back home. But for that year, she was actually staying in our program for 2 years, they could sort of have a different family dynamic, and it wasn't really all about Samantha. That being said, not really answering your question, is where can you meet that child and sort of draw those connections and sensitize your kids, and also maybe have an understanding with your other kids is, what is it like for you when, I'll use your sister acts a certain way, or when things get difficult, what's going on with you? Maybe addressing that with them separately, to find out what they need and what they want.
Okay, thank you. I'm gonna end off asking each of you, maybe you could repeat something that you said earlier or add something new. There was a lot of questions here asking for like the best therapy or the best intervention. Maybe walk away with, to share one tool. You have with a parent who has a child with a diagnosis. One tool you would leave with them, one thought or tool that you would leave with the parent. Dr. Fox?
I'm thinking over the ones that I used in my presentation, and of those, I guess I would pick first up, when you're stuck, seek professionals who see the best in your child. And I just think that's really, really important. And also trusting your gut as well, because you know a lot about your child.
Okay, that's two. Thank you. Dr. Glass, could you share one, or if you'd like two, now that Dr. Fox,
I sneaked one in, yeah.
Right.
Right. I think I want to just connect to, again, something that both Dr. Fox and Liz said earlier, to encourage parents to be optimistic. Care is often sought at low points, at crisis times, when things have fallen apart or about to fall apart, when things have not worked out in a school or in a program. And so typically help is sought at a low point. Sometimes parents can really be, understandably, quite pessimistic, either about their child's future or about their ability. And usually with the proper help, with time, with help from above, people can turn things around. Sometimes it's by providing skills for the child, changing the environment, improving parenting skills and techniques. And so there's on the one hand, I validate and support parents in their suffering and in their sense of loss, but really try to infect them with an optimism. And if I won't do Dr. Fox's adding a second one, but maybe a part B of the first one. A lot of times, having a livuy, an accompaniment by a therapist who is able to tailor make a program over a period of years for the child that combines working on the child's own skills, parenting skills, and finding the proper setting. Oftentimes, a hadrachat horim type of intervention can, over a period of time, can really turn around even the stormiest of voyages. So that optimistic point is I think what I would like to leave people with.
Okay, super. Elizabeth, please.
It reminds me of the Welcome to Holland poem. If anybody's familiar with Welcome to Holland, it's a beautiful poem about expectations of, you think you're about having a child with a disability is like taking a trip to Holland and you get your books and you're excited, you're going to go see the tulips and all the wonderful things of Holland. And then you get off the plane and they say you landed in Italy and there you have to stay. And as much as you're disappointed that you spent your whole life preparing to go to Holland, but Italy has, the Michelangelos, and Italy has amazing pasta, and Italy has the Arno, and I love that positivity piece. So that wasn't my one, but it was my extra. I'll just my addition, I think, is I'm sort of like looking at this Zoom. There's at this point 58 participants, and I'm gonna throw out, I didn't add this, but community. There's a whole group of people on this Zoom that I personally don't know. I also can't see all their faces, but and as much as we're talking about being the parent and we know our kid the best, and we're talking about professionals, but there's a whole community of you out there, and my suggestion is utilize each other, find your communities. I think you don't have to reinvent the wheel, but also find that support, find that humor, find that connection. For your child, but also for yourselves. And I think that perhaps, when Robbie will, make this sikum, there might be a whole group of people out here that you can now utilize and each other's support.
Great, wonderful. All right. Well, thank you everyone who joined us this evening. Thank you to our speakers, Dr. Fox, Dr. Levin, Liz Cohen, really from each of your perspectives and each of your nuances. Whether it was, really defining the behaviors, whether it was really looking deep into the individual above and beyond the diagnosis, or whether it was, the acceptance and the mainstreaming and the taking those risks, even if they're not always going to be successful. I really appreciated everything that I heard tonight. We are going to send a copy of the video out to everyone who registered. And again, Hakarata Tov to Nechama again for organizing the evening. And we look forward in another, I don't know, few months to be able to offer something else on a different topic. And wishing everyone a good night. We want to honor people's time. 9:36, we're 6 minutes late. And have a good night, everyone. So thank you.
Thank you.
Thank you.
Thank you.